Welcome to Derm-It Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. On today's show, I have Dr. Steve Feldman, professor of dermatology, pathology, social sciences, and health policy at the Wake Forest School of Medicine. Dr. Feldman ranks among the top experts in the world on psoriasis by expertscape.com, and he also serves as the editor for the Journal of Dermatological Treatment and the Journal of Dermatology and Dermatological Surgery, and as chief medical editor of the Dermatologist magazine. Welcome to the podcast, Steve. It's great to have you here today.
Oh it's my pleasure to be with you. Thank you so much for inviting me.
Well, I'm really excited to have your expertise on today because I want to talk a bit more about psoriasis. A lot of people out there listening know somebody who has psoriasis or maybe even personally has it, but what they may not really realize is that psoriasis is kind of that cliche we say more than skin deep. So I was hoping to kind of have you talk a little bit more about psoriasis as more than just a skin disease.
Yeah, so I started seeing patients with psoriasis 30-something years ago, and the situation has evolved considerably. I think we used to spend a lot of time talking about how it affects people psychosocially and how to explain to friends that it's not contagious, how will see you in the stores and and children will point, or lifeguards won't let you into the pool. Hey, now we have drugs that clear the skin up. And so now, instead of focusing so much on the psychosocial aspects of the disease, we're more focused on clearing people up and the internal manifestations. I think we always knew that it affected the joints in like a third of the patients. I'm here at Wake Forest. The guy who did psoriasis before I got here, the wonderful Michael Zanoli, he did a survey of all the patients he was seeing with psoriasis, and I think was one of the first people to document that about a third of the patients have psoriasis affecting their joints, causing stiffness, pain, swelling. Now, the folks at the University of Pennsylvania, back about 15 years ago, did this seminal study, a real landmark study, using data from British primary care doctors, showing that psoriasis is associated with a clear, distinct increased risk of heart disease and related vascular blood vessel diseases. And that opened the floodgates. People started looking for all kinds of other associations and finding all kinds of things associated with psoriasis.
So kind of what you're saying, it's just so, especially for our listeners, because when they have come in, they have psoriasis, obviously, like you mentioned, focused on the skin. Traditionally, that's where we've been. Now we've got great medicines that basically clear up the skin. But now we're looking at problems that are associated with psoriasis that patients might have, like heart disease and joint or arthritis, as we call it, or joint problems too. Beyond those two, are there other things that somebody with psoriasis should maybe sort of stop and say, okay, maybe I'm at risk for other things as well?
Well, yes and no. So we Americans are at a high risk of having depression. We have it really good here, but we still get depressed. And there's an increased risk of depression in patients with psoriasis. Hopefully, really good treatment reduces that risk, but I'm not sure we have strong data to tell us one way or the other. And then there's all kinds of other things. I had one of my students make a list of all kinds of things that had been associated with psoriasis: kidney disease, melanoma, aortic aneurysm. So like the big blood vessel that leaves your heart just blowing out, all of these were associated with increased risk. There are many other conditions. But I'm not saying that your listeners should be worried about any of these. I'm just saying there's association. And some of these associations are based on studying millions of people, claims data on millions of people. And they can find statistically significant associations, which gosh, the people who do the study get all excited about and write papers and publish, stuff that gets into the lay literature saying there's an increased risk of XYZ. And, it may not be clinically meaningful. One of that study that student of mine did, he looked at the thing that had the highest risk. There was a 6-fold increased risk of having a melanoma. Now that sounds bad, right? But
Right.
it was a study done in Taiwan where melanoma is so rare that it would have taken 20,000 people with psoriasis before you would see one more melanoma. So yeah, it's statistically associated, but it's clinically meaningless. The heart disease one, it's kind of glass half empty, half full. Probably not a bad idea to eat a healthy diet, get regular exercise, get your your cholesterol checked, and take something for cholesterol if you need to. But everybody should do that, whether they have psoriasis or not. That first study that the folks at University of Pennsylvania did found that if you had bad psoriasis, you were at like a 3-fold increased risk of having a heart attack. That sounds bad. Well, that was 20 to 30-year-olds. If you were between the ages of 20 and 30 and you had bad psoriasis, you were at a 3-fold risk of having a heart attack. But what's the risk that a 20 to 30-year-old without psoriasis is going to have a heart attack? Roughly. It's roughly 0. It's really small. 20 to 30-year-olds don't usually have a will because they're worried about having a heart attack. So you multiply that by 3 and it's still pretty close to 0. It's like almost no increased risk at all. There might have been like a 20% increased risk if you were like old like me. Okay, that's a much bigger risk than the 3-fold risk in young people.
So if you had a psoriasis patient coming into you and they're Googling because that's what everyone's doing nowadays and say, okay, I've got psoriasis, so I'm worried that what else could I be at risk for? And they get that laundry list of things you talk about, like heart disease or, metabolic syndrome where they carry more fat around the center or they're resistant to insulin, more likely to get diabetes or high blood pressure or high cholesterol. And then they even read, oh gosh, like you could have associations with increased risk for certain types of cancer, which really kind of freaks everyone out when they find that online. How do you practically break that down to say to them, these are truly the things I'm potentially worried about that you could be at risk for and that we might need to do a little bit closer monitoring for?
Yeah, I'm in North Carolina. I don't get a lot of questions like that. I'm in New York City, big city, Chicago, Los Angeles. The things would be different. But in North Carolina, I don't know that I've had a patient yet come ask me about the comorbidities of psoriasis.
Okay.
Typically, what they ask about is when I give them a biologic for the treatment of their skin disease, they may say to me, is there, risk from this? And I'm like, probably we're reducing your risk of heart disease more with this than you're actually going to have risk from the treatments. If somebody did ask me that, I would say, look, yeah, are you having any morning stiffness, any joint pain, any back pain, signs of psoriatic arthritis? That would be something worth looking out for. I generally look at people to see if they're having signs of depression. I usually don't ask them about depression, but if they're sitting there like this, then I'm going to ask them questions about depression. The rest of it, I don't pay much attention to at all. I think if they're clearly overweight, I will bring it up with them. And whether they have psoriasis or, there's good treatments for obesity nowadays, and obesity is clearly linked with stuff. I'm involved with another University of Pennsylvania study. You may want to get them on the show if you haven't already, talking about it, where we're looking at the patients who are 40 and up and seeing if they've ever had their lipids checked, had their cholesterol checked, had their blood pressure checked, and we're checking those things and giving them advice when needed. Look, I've got high cholesterol, all right? And I've looked at the numbers. If I take my statin that they've prescribed me and keep my cholesterol down, it should reduce my risk of having a heart attack over 10 years by 30%. which sounds like a lot. But what that means is my baseline risk is 7%. A 30% reduction takes me to 5%. And I'm scratching my head, does does this 2% difference make it worth taking the statin? Well, the statin costs me almost nothing. It's easy to take a pill every day. Okay, fine. I'll do it for the 2%. I'm not really excited about it. I don't think it's really going to change anything. I asked my preventive cardiologist, should I take the statin for this 2% difference? He says, if you're one of the 2%, it really matters a lot. I'm like, all right, fine. But does it really, if there's any significant side effect from it, or if it costs a lot, I'd probably blow it off or something. But if psoriasis has as big an effect as cholesterol, and treating the psoriasis reduced the risk as much as taking a statin does for cardiovascular disease, and we don't know that it does, but if it did, for most people, it's probably going to make a small change. Now, that's what I would tell a patient if they came to see me. If I was giving a talk to insurers about how important it is to pay for the cost of these high-cost biologics for the treatment of psoriasis, I would tell them, patients with bad psoriasis can be up to a 3-fold increased risk of having a heart attack, because I want them to pay for the drugs that my patients need for the skin.
But the math is important, though, like when you bring that up. But I understand it's more profound when you say it that way. But when you look at the numbers, you're right. Like it's, what's the true impact? Like, does it make sense? So if you were, like some of my patients, so I'm in Central Ohio area, and I have had people come in, they Google and ask that, and I think, gosh, like, how do I break this down? It sounds like your advice would be, really look at potentially that cardiovascular disease risk and the risk for arthritis. Those are the top two that you kind of hone in on as being most clinically significant. Would that be a fair kind of assessment?
That, and I think the depression might be the most common thing, because so many Americans are depressed anyway. If you're at any increased risk, that risk is probably up there with psoriatic arthritis in terms of the percentage of psoriasis patients who have depression. But then you can pretty clearly recognize that when you see it up front. So screen for that, screen for the arthritis. And the cardiovascular thing, the neat thing about dermatologists is we get to see everybody. We get to see young people, we get to see old people. We get to treat men between the ages of 20 and 45 who may not be going to a family doctor. Women, they're probably all seeing somebody, but the guys,
Oh, yeah.
they go decades without getting their blood pressure checked, without ever having their lipids checked. So this is an opportunity that we could do for all our patients, but since psoriasis patients are at increased risk, they should certainly get the recommended screening, which probably is blood pressure and cholesterol checks.
I think that's, I love the way you say that, because it really shows too, from the standpoint of dermatologists, how we can have an impact on somebody else's health. Because, like you said, men don't utilize healthcare, resources like women do, and just to be able to get them through the door because they just happen to come to you because psoriasis bothers people, right? They see it on their skin, and so they're motivated to come in. But, to get that blood draw, to get their cholesterol checked or get their blood pressure checked, not real attractive. It's why I went into dermatology, because when we cleared somebody's psoriasis, you could see the impact it had on their quality of life. The patient that I had got off disability, his depression improved. He was dating by the time I had left that rotation that I followed and worked with a colleague throughout a year's time. I thought, man, I want to do that. You lower somebody's blood pressure, by 10 points, they could care less, right? So I think that's a really important message to take home for clinicians out there, that you can get people to the family doc for that. But if you're talking about the biologic medicines and you're like, okay, yeah, I want to put you on something like this, it's going to definitely help clear your skin, may help improve the joints, but the patients are like, I don't know, I'm kind of worried about the risk. Like, how risky do you feel like in general psoriasis treatment is? Like, how do you present that to the patient?
Yeah, I basically tell them for a lot of these things, there's no risk at all. Some of these powerful drugs, it's like we're in an age of miracles. When I started 30-something years ago, I had chemotherapy drugs like methotrexate, or something to turn off your immune system like cyclosporin for patients with really bad disease. Or I could, really Stone Age, I could cover people with tar and give them ultraviolet light treatments. Now I got drugs, you might take an injection every 2 or 3 months, And if they ask me what the side effects are, I'm like, I don't think there are any. I mean, I like nothing. I mean, the studies show lower rates of serious infection on the drug than off in the placebo group, maybe more common infections, but I think the common infections occur for an absolutely fascinating reason. You see, I think psoriasis is a socially disabling disease. So if you're in the placebo group, you just do what you normally do, which is sit at home miserable with skin lesions, flaking, cracking skin if you move, joint pain, depression, just sit there watching late night television, smoking with one hand, drinking a beer with
They're
another.
listening to the podcast. That's what they're doing.
Maybe listening to the podcast. I love that. But if if you're in the drug group and your psoriasis clears up, your joint pain gets, you're like, I feel great. I'm going to go visit my nephews and nieces who have runny noses and diarrhea. I'm going to, go to the bars, meet men, women. I could go either way this week. I'm going to go to the Y, maybe exercise and be with people. Maybe I'll take a shower there, maybe without flip-flops. You could be exposed to all kinds of common infections, once you clear that psoriasis up. So some of the treatments, the very good ones, might have a risk of a yeast infection, or maybe 1 in 300 people, it might exacerbate their inflammatory bowel disease or cause diarrhea or something. Some of them may have a little bit of, like 1 in 100 patients might get shingles, but you can treat that ahead of time by having them get vaccinated. Yeah, there's just so many great options now.
I think with all the options too, it's interesting, on TV, you see commercials, or hate to say it, a lot of my patients, especially my younger ones, they don't watch TV, but through streaming, or if they get forced through a commercial, on their Amazon Prime, they might see an ad for a psoriasis medicine, and I think it's interesting to just think about, like, why do we see so many of these going around? What's your explanation for all the advertising, especially the way they've kind of gone out to the patient to make them aware of what's out there?
Yeah, I think historically doctors didn't like direct to consumer ads. I love it. I like my patients to be educated, by
Hmm.
commercials and podcasts you know, and I think the commercials they're required by federal law to provide a balance. So you hear the supposed side effects, if anything, that scares people. And I have to tell them, don't worry about those things, because they saw those in the placebo group too. Um,
Hmm.
yeah, I think it's happening because it has become legal. It's because these are consumer products. Patients are involved in the decision making of what to do. It does, as you said, increase awareness. I think it's great that people with psoriasis, especially bad psoriasis, we got treatments that clear you up available to you. And gosh, one thing your listeners should know, one of the things that really bothers me is when a patient tells me, I didn't come in because I didn't have insurance. I knew I wouldn't be able to get the drug. Hey, the easiest patients to treat are the ones who are poor and are uninsured, because I can get almost any drug for them free nowadays, from all the companies. And there's so much competition between these drugs that, they want patients to know about their drug so that they'll ask their doctor for it.
So you see all these medicines that have come on the market, especially since back, as you mentioned, in the dark ages when we're using coal tar and things like that. Where do you feel like the future then for psoriasis treatment is headed? Since we've come so far, our expectation of getting the skin clear, I mean, we used to think, yeah, if we got it 75% clear, 90% clear, now the expectation, 1% or less, or, getting up to 100% clear is kind of the new bar or standard. Where do you feel like the future is, and how does your research play a role in that?
Yeah. Okay. Well, there's two kinds of psoriasis, I think. A limited kind with just a few spots that would get better with topical, with creams and ointments and things. Then there's a more extensive involvement where you're not going to possibly put creams and ointments on all these spots. For the people with mild disease, which is the vast majority of people with psoriasis, just a few spots on the elbows and knees, um, the biggest limitation to the treatment is that the patient isn't putting it on. And so I think, and my research is on, trying to encourage people to use their medicine better. If they would put that clobetasol on their psoriasis, man, that stuff is fabulously effective and clear it up. We did studies with, computer chips in the caps of the containers that recorded the day and time people would open and close the containers. And in the studies in their treatment diaries, they say, oh, we put it on twice a day. But the computer chip says you're not opening the bottles, So
Liars, what the chip said.
I don't know that people are lying because I think people think they're doing it more than they really are, but they're not acting. It's so
I think was your study the one too that showed they do it more consistent when it gets closer to the appointment with dermatology or their
oh my God,
dermatologist
yes.
doctor? I thought I remember reading that at some point.
Yeah. If you have ever heard the mother of an acne patient say, so frustrating, you always catching on a good day. Oh, why? Now you know why. Yeah, I think people floss their teeth right before they go to the dentist. Now I floss my teeth every day, but if I have a dental appointment coming up, I start flossing twice a day.
You're right.
When do people practice piano? They do it like right before each lesson. Doctors are kind of like a piano teacher who says, here's a prescription for some sheet music. Take it to the sheet music store. I have no idea what it's going to cost. I want you to fill this prescription for the sheet music. I want you to practice every day. We're not going to have weekly lessons. Just practice every day. Practicing may cause rashes, diarrhea, possibly a serious infection, but I want you to practice every day. I'll see you at the recital in 3 or 4 months. And if the recital doesn't sound good, which it often doesn't, I'll give you another musical instrument, 2 or 3 more musical instruments to practice at the same time. Yeah, what we're doing sets people up for poor adherence to the treatment. And so, if anybody's listening and their doctor prescribes some clobetasol, I would encourage them, try doing it really well for 2 or 3 days and then call me and let me know how it worked. Because I bet it's going to, you could see the effect of clobetasol in just a few days. Now, for the people who have really extensive disease, I think the future is already here. We got drugs that, you only take them every 2 or 3 months. One of my patients today on an every 2-month drug for their psoriasis said, you may not want to hear this, but I haven't been taking it. I stopped in October and I'm still clear, so I'm not taking it. I'm like, I don't mind that. If you don't need the risk. I don't know if there is any risk, but you don't need the tension. If there is any risk from the drug, minimize it by taking the least you need. It's going to save money in the long run. Yeah. And if for some reason it stops working because you're not taking it regularly, we got other choices we can get you on.
Fantastic. Well, thank you. This has been a great conversation, and I mean, just kind of going over, really should people worry about, and there's so much information on there on treatment and risk, and underlying health issues that can be associated with psoriasis. So I think we really broke it down nicely for our listeners to kind of get a nice grasp on kind of the basics of that. So thank you so much for coming on the podcast with us today, Steve. I want to give you an opportunity though, if our listeners want to find you, where's the best place for them to track you down, maybe online or elsewhere?
Shannon, it's been an absolute pleasure being on with you. The best place to find me would be a literature search of the medical literature, because then you can see all the stuff, my minions have been publishing for the last few years. I got a Facebook page and a Twitter presence, and you can find me there too.
Great. Well, be sure to look up Steve. He's, like he said, he has had multiple publications in this space, a true expert on psoriasis. So thanks again for coming on the podcast. We really appreciate your time today. And for those of you out there, stay tuned for the next episode of Derm-It Trotter, Don't Swear About Skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.